back, everyone. As we continue the Health Impact series on the future of healthcare workforce, we are talking today with Melissa Kozak. Melissa is a registered nurse and the founder and president of CitusHealth. I met Melissa a few years ago at, I think it was Health Impact, it might have been DMC, where she had just started Citus. We'll discuss innovation on the front lines of healthcare, hear Melissa's founder story, and talk about how to develop technology that makes healthcare better for patients and healthcare workers. Hi, Melissa, how are you?
I am doing very well, Megan. Thank you for having me.
Thanks so much. And of course, we have Janae Sharp here today as well. Hi, Janae.
Hi, I'm really looking forward to hearing about this because I've spoken to so many nurses and nurse executives who want to start something, and they're like, we need to talk more about how to do that.
That's great.
100%.
I'm so happy to talk to you all today.
So Melissa, tell us about that. Tell us about your experience as a nurse and how, what led you to start Citus.
Absolutely. So I began my nursing career in New York City, working at Lenox Hill Hospital, actually, traditionally in a med surg floor, which most nurses started out at, and then transferred to the ER. And I actually had a physician colleague ask me if I would see one of his patients in their home, sort of after hours. And I did that and absolutely fell in love with this idea of seeing a patient in their environment, actually in their home, see what kind of family support they have, what neighborhood they live in, what kind of access they had to food, what was in their fridge, really how they lived, not, sort of how they tell us that they live. Mm-hmm. And I realized, I looked into home healthcare and realized, wow, there is a whole field of home-based care, which is really care that happens outside the four walls of a hospital. So I ended up getting a job for a home infusion provider. So, home infusion is where patients learn to self-administer all sorts of IV infusions instead of going into a hospital, or after a hospital stay, they either self-administer or they administer it to their loved ones. I just fell in love with the field and worked, for various home infusion providers for about 8 years. And while I loved the innovation that was there that allowed patients to have that level of care in the home, which of course kept costs down, it was their preferred site of care. They had terrific outcomes, health outcomes. What was very evident to me early on was, while there were systems of records in place, so think about EHRs or EMRs, what there wasn't available was a way for those patients between nursing visits to get support when they needed it. So unlike a hospital where there's really care around you as the patient 24 hours a day, when you're in the home, you may have a nurse visit you for 1 or 2 hours once a week. And in all that other time, you're essentially on your own. And the only tools available to those patients to get support were the telephone. So they'd have to call an 800 number, be transferred, wait on hold, get hung up on, play phone tag. And by then, there could be all sorts of issues, fear, they're running off to the ER, et cetera. And then on top of that, because it's outside of a hospital, that care team, which would include nurses like myself and pharmacists and administrative team members, we're not standing in the same room together. So how do we connect and coordinate that care in a way that is timely and doesn't cause delays to the patient? And that's also really hard when the tools that you have in place are mostly phone and email and disparate systems that don't integrate with each other. So that was really my impetus to start CitusHealth, was how do we put together a platform that can streamline these things, that can help patients get good support when they're not with their nurse, and help nurses like myself and my colleagues communicate with each other.
Right. That's great. Well, I used to live across the street from Lenox Hill Hospital. So you could have come and given me a home visit. I literally lived right above the subway there.
Oh my goodness, that is my old stomping grounds, Megan.
Do you remember? So there was a bagel shop on the corner across the way.
Pick a bagel.
Yep. Yep.
Pick a Bagel, yep. And across the street from Pick a Bagel is Loft Opticians, which is my dad's eyeglass store for the last 45 years.
Oh my God, no way. Oh,
Oh,
that's
that's
crazy.
awesome.
Oh,
Indeed.
how funny. I never knew that. Well, that's amazing. Well, that's interesting. I mean, just how you went from sort of in the hospital to home health, which I think, right now, obviously, and certainly during the pandemic was, such a big thing. In doing that, was there a particular moment, in doing that where you felt like that was, there's something I can solve here,
Yeah. What was the tipping point, kind of?
Yeah, and there definitely was a tipping point, but it was because it kept tipping until there was that point where it fell over. It was really like a death by 1,000 cuts. So, it would be things like I would get to my patient's home and it would be my 6th patient of the day traveling around the subways and buses of Manhattan. And oh man, that patient didn't have the supply that I needed to be able to care for them. So I had to call the office, which was in Long Island, and wait an hour and a half to get the supply after I've already done like a 12-hour shift, or, that the patient had been waiting to hear back from the office just to find out if they're authorized for more visits, or do they need to go back to the hospital. Or I would be asked at the end of a long day to go back to a patient's home to get a piece of paper signed and then drive it back to the office so that billing could occur. So it would be things like this over and over again. And my patients just telling me, man, Melissa, this is really hard. Like, getting this care in the home is an awesome thing, but communicating with you guys is really hard. And so that final straw for me was, I had a patient who was on an intermittent infusion device. He was being treated for a condition called endocarditis, which is essentially an infection of his heart. So very serious condition, absolutely needed his infusion device. And I came to see him one morning and he was very distressed. He had told me that he had been up all night. The pump was alarming. It was keeping his wife up all night. And he was essentially trying to get help from the home infusion provider to help troubleshoot the pump. And he was calling a number which was routed to a call center, and that call center could not get a hold of the pharmacist on call. And essentially he was so frustrated by the experience that he unplugged the device. And again, this man was being treated for a heart infection. So that is just an example of a very dangerous potential adverse event that could have happened to this patient of mine. And that was my aha moment. I said, man, why couldn't there be something in place for him to have sent a secure message to the right person on call, it get routed to them, or maybe have an educational digital library available to him where he could have potentially tried to troubleshoot the equipment himself. But that was what started my journey that day forward. I knew that I wanted to do something to make this better.
That's awesome. So how did it work? Like, did you talk to the organization? Like, were they supportive and excited for you? Like,
yeah, I did.
Support.
Yeah, so I did actually talk to the organization, and at that time in my home infusion nursing career, I was working for, I think, the largest home infusion provider in the country. So I sort of naively thought I could just tell them this great idea and maybe they would fund it. And then, I'd get it rolled out to all of their 50 sites or 60 sites. And you know how it is in a big corporation, you have to get to the right people. So I got a lot of, hey, that's a great idea, Melissa, but we can't really help you. So it was more me kind of going out on my own to try to figure out how do we get this built. And there was no objection from them to go, figure it out. But at first there wasn't going to be any sort of financial support or anything like that. So that kind of began the entrepreneurial journey. And one of the first things that I did was figure out, is this really a need, or is this just me? Do I just think this is a need, or do my colleagues feel this is a need? So I started talking to other nurses. Do you guys feel this pain? Is there this much friction in your day-to-day life trying to care for your patients? And I would go interview my patients. Hey, tell me about your experience. Is this really painful? Would it be better if you had maybe a mobile tool to connect with me and to connect with your care team? And I just did searches on all the major home infusion companies' websites to see, did they offer something like this? And there wasn't anything like this. And everyone that I talked to said, yes, indeed, this is an issue. And that large infusion company that I work for, they actually were PBM owned, and a very sophisticated PBM, and they didn't have anything like this. So that was enough for me to conclude that there's a real need out there. And, what I went and did after that was found myself a very brilliant technical co-founder named Shahid, and Megan, you know him well and work with him. And we started from there.
Mm-hmm. Yeah, I mean, it's kind of amazing. I mean, for context, what time frame was that? When was it?
2015. It was
Right.
actually September of 2015 was my first call with Shahid, and I had come up with the idea just about a month before.
Yeah. So that's kind of, I mean, it's just crazy to me that, I mean, because it's not like home health was new for nurses, at that point.
Right.
And like, so what was the communication like? Was it just not centralized at all? Or was it not patient facing at all?
It was not, you're right, it was not patient facing. So there were EMRs, and those were not built for they weren't built for patient first communication, and they really weren't built for collaboration of care teams. It was more to house a medical record. It wasn't real time communication where you can, talk and have these conversations to coordinate that care and intervene when things are going awry. So it was more one-to-one support. It was, hey, you have an issue, call this number and we will put you in touch with the right person. And after that right person speaks to you, that person then has to go reiterate the conversation in the EMR. And then that nurse in the field who is then going to see that patient who maybe the day before had that conversation, doesn't know that that conversation took place because they don't have access to the EMR in the field. So they're going into the home sort of blind, not knowing that this issue had occurred with the patient, or maybe the patient needed a certain supply ahead of time. So it was that type of disjointed thing that would lead to patient frustration. It would lead to nurse frustration. And we're talking about, clinician burnout. And I know we're going to talk some more about that. But it's really tough on a nurse when they go into a home and don't know a critical piece of information about their patient and that they could have prepared for ahead of time, had the right thing, pulled in the right order, whatever it is, and they're there. And now they have to go backtrack, maybe leave the home and then come back. So yeah, it was just not one-to-many communication in real time where everybody could know the whole story. It was very disjointed and still largely is.
Right.
So
I mean,
nurses,
I just had for the first time, so, in my, my charts and all that for my kids, you can go request an appointment, right? So that feature's been there, but it always results in a phone call. It never results in them just making an appointment. And that for the first time, I just got a notification that I have an appointment set. And I was like, wow, something works. But it is, and it's like, it's syncing up the async with the real-time communication. And that's just appointments, which is not, it's like really what you would think would be the easy stuff, right? But that's great. I mean, just in terms of, finding the problem and then, coming up with the solution. Shahid is also very good at that.
yeah, he's very good at it. It's
Yeah,
cool
he
that
is
you
good at
thought of
that.
it. Also, it's interesting. I didn't know that they didn't have access to the EMR.
Yeah, so some organizations need to provide a VPN connection for their nurses to access, others don't. And and sometimes those notes don't sync back to the EMR in real time.
Oh,
So
yeah.
always, yeah. So there's
Good
those
times. Good
issues.
times.
Or it might be a rural area where they don't have connectivity. So there can be lots of reasons, or some of those previous conversations with paperwork with patients were on paper and not yet uploaded to the EMR. So lots of reasons why that nurse can go in without all of the information handy.
Yeah.
Mhm. And now, as a female founder, kind of creating a technology, software in healthcare in the last 7 years, which has been an interesting time. Certainly we've seen a lot of adoption. What were there any interesting experiences there? I mean, it must have been, sort of how do you get from having the idea to then, now selling the company and being part of that?
Ooh, we are going to need more than a half hour
Yeah.
to get into that. But,
Just a tiny question. Female founders, go.
well, the female founder thing, I have to say, I really, I had sort of been primed that, females, compared to men, raise less venture capital funding. They certainly, much smaller percentage are founders. But it didn't get in my way. It didn't get in my way because I just had a will and a determination, and I just knew there was a problem. And I just had the mentality of, I'm going to do whatever it takes to make this thing happen. So I never felt when I walked, because we raised several rounds of funding, VC funding, angel funding, et cetera. I never felt a disadvantage as a woman. That is not to say it's not real for some women, that there is actually a disadvantage. I think my mentality was just, I know what I know here, and I need to find the right funding partners to go bring this to life. And so I didn't let that hold me back. So that's the female founder part, but how to get it from ideation to successful exit is a huge journey and a huge story. I would say, the first part of it was finding a co-founder, and who was a very experienced technologist, had started companies before. He had been a co-founder before many times, and he had a passion for solving big challenges in healthcare. And he always wanted to partner with a clinician who really knew the workflow. So we were sort of a match made in heaven from that perspective. I was a first-time founder, first-time CEO, zero business experience. I think what really helped me is I didn't know how hard starting a company was. I think if I knew that it was a Mount Everest journey, I probably wouldn't have taken the first step. But I think I thought it was like a hill to climb. So that was good. I had that in my favor. And getting healthcare companies to part with money is not an easy thing. It is not easy. It's not easy for them to write a check, and it's certainly not easy for them to open up their networks to new software when they're so concerned about security and patients' data privacy. So it was a lot early on about talking to customers, getting them to identify with the problem that we were solving, and relentlessly speaking to them until those first few early adopters said, okay, I'll give you a chance. I'll give you a chance in a very small way. And so we built an MVP, right? That minimal viable product, which came from my ideas and, what I experienced as a field nurse. And we put it in the hands of those few early customers, and we got that feedback and iterated the product. But I would say the next smartest thing that I did as an early CEO is my first hire in the company was a nurse named Terry Embry. She's still with me today. And she had 25 years experience in home infusion and other home-based care markets, but way more operational experience. Whereas I was a bedside nurse, I knew one part of the workflow. She knew everything from the moment that prescription, that referral came in the door, through the insurance verification, the whole revenue cycle, all of the operations. So she was able to say, oh, that MVP is great, but here's 2 more things we can add to the product that are going to make the ROI just skyrocket. And so we added a little bit more there. And it was those early customers who, gave those prospects a little FOMO, like, wow, if they're using it, maybe we should try to use it, right? And just not running out of money really helps. I mean, you gotta not run out of money when you do this, and you just have to.
That's like a great playbook. We need like facts. Like, here's what you need to do: find awesome people and not run out of money.
That's it. And be able to get, punched in the face a lot and get back up like that. That's really. And then just believe in what you're doing. And you know what? I think Shahid always believed in what we were doing and believed in me. I had a lot of sort of baggage that, I doubted myself and I doubted it. But at the end of the day, there was a belief in what we were doing that just kept me going. Because let me tell you, we have over 100 customers now that span from home infusion, specialty pharmacy, and home health and hospice. And we're owned by a very big company now. But in the early days, I would get, 50 no's for every yes. And that's hard to deal with, and you gotta just keep going. So yeah, don't run out of money, hire really smart people, great dedicated people, and just keep getting up. And that's what we do.
I love that.
Amazing. Well, and then you just got recognized by Crane's New York Business as the 2022 Notable Healthcare Leaders. So congratulations on that.
You got an award.
So much success.
Yeah.
You send it to all your old bosses.
But I was reading the
I didn't, but that's a good idea. It's like that Pretty Woman moment. Big
Right.
mistake. Huge.
every no gets the press release. But
Right.
I was reading it and you mentioned, obviously the pandemic, right? And how that changed healthcare and how the remote work for all nurses and everyone, has changed it. So tell us a little bit about that experience and what you learned and what that means, kind of for the company and the technology as you see it.
Totally. Well, listen, the March 2020 days, everybody was in a panic, and I lived in New York. So we were like one of the first areas hit really, really hard. And from a software company perspective, we were just like, well, how do we help? What do we do? How do we help? And what we saw, of course, were patients didn't want their nurses to come for visits. They were scared of getting infected with COVID. They didn't want the families didn't want to go see their loved one and possibly infect them. So you have these patients isolated in the home. They're not having their family support. They're not necessarily having the visits from the clinicians. So what do they do? And, early on, what we did is let's just offer our platform out to anybody who wants it. Like, forget about fees, forget about charging. So here we have video chat technology that allows that patient to get on, kind of like what we're on here, but HIPAA secure, and connect with that nurse remotely. And then that nurse can loop in the adult daughter across the country and the adult son in another part of the country and see that mom is doing okay. So it was
amazing.
Really, yeah, it was rapid adoption of kind of these concepts that we had in place, but it became absolutely necessary at that point. We were servicing one of the industries that we were servicing, specialty pharmacy. This is an industry where patients are diagnosed with very rare diseases. They are on medications where one pill can cost $4,000. And they were terrified. Am I going to be able to get my life-sustaining medications? What's going on with the supply chain issues? I can't get in touch with my provider. And so we offered tools that allow that patient to track their deliveries and securely message with their pharmacist to find out, yes, indeed, they are going to be getting that medication, and submit early refill requests. And the feedback from the patients through the pharmacies, which were our customers, were things like, thank goodness for this platform, because I was so scared that I wasn't going to continue getting my healthcare and getting my medication. So that's really kind of early on. It was just, how can we help in any way? How can we make some of this stuff contactless, where in the home health world, it's pretty ludicrous, but you still have to get pieces of paper signed for providers to get paid. And how can we make that digital so that that piece of paper can be sent electronically to that patient? And so that was really what we focused on, safety of the patient, safety of the clinicians, but that continuity of care. And then on the care team side, where all of a sudden you had many team members who worked in an office, now they're remote. So you have this whole remote workforce, and how do they stay in communication with one another when they don't necessarily have all the tools in place to do it? So we saw rapid adoption of a feature of ours called patient discussion groups, which is essentially like a Teams thread, but about a patient, without the patient being in it, just the care team, and everybody was able to stay connected and know what just happened with the patient, pass the baton on to their care team member, and really just keep that care going, even though people were working from home and not in the office anymore. So that's what we saw. And here we are coming out of the pandemic, and those technologies, because they worked so well in this trial by fire, are continuing to go. And what we're seeing is that these providers, these patients, are just not going to go back to how it was, pre-2020.
That's fantastic. Like, I think we should also just talk a little bit about things now, because nursing is kind of a hot topic lately. So maybe we should talk about that. Like, what people are talking about tech burnout and tech to solve burnout. At the same time, they're talking about, challenges for home in-person care. There's just a lot. So I'd love to hear your insights about like nurse burnout, whether that be in like the home healthcare, realm, or how things are now after the trial by fire.
Sure. And listen, I go to a lot of conferences, and the number one topic, whether I'm in a home health, a hospice, a home infusion conference, a hospital acute conference, it's retention of nurses, it's recruitment of nurses. This absolutely is a hot topic. We know that the pandemic drove so many nurses out of the field, just from the sheer stress of the pandemic, the increase in caseloads, the decrease in staff members to share that workload, drove early retirement, all of those types of things. So that burnout is real. Growing up as a young nurse, it really was the culture of nursing. This is way pre-pandemic. It might sound silly, but it was empty stomach, full bladder all the time for a nurse. And it was this idea of, it was never put the oxygen mask on myself before I put it on the other person. It was always put it on the other person, and doesn't matter if you choke, And that was before there was this clinical shortage. So fast forward to, this global pandemic and this shortage of nurses. And now you've just removed work-life balance more than ever before. And so our focus has been, it was before, but it's even more, how do you take away the repetitive, non-clinical, administrative, busy tasks from nurses that prevents them from having their hands on patients, which is why they got into the profession in the first place, that keeps them doing paperwork well into 10 o'clock at night on their couch, not being able to be with their family or have any downtime or have any shift in their day. How do we help them? Technology is not a magic bullet. We can't make nurses out of thin air. That is a problem. And absolutely, there has to be that pool of talent needs to be developed, and working with nursing schools and all of that. But in the meantime, how do we give hours back to the nurses that are there? on the front lines. And we've found ways within CitusHealth and certainly other technology platforms, I'm sure have done this as well, to make it so at the end of the day, that nurse doesn't have to call 6 or 7 patients to set up their visit for the next day. They can just send a simple message to coordinate that, or they don't have to go drive a piece of paper from a patient's home 45 minutes away to an office so it can get scanned into an EMR. So billing has occurred, or they don't have to be woken up in the middle of the night by a text message or a call from a patient saying that they're having a rash, because that nurse is so nice that they give out their personal phone number to the patients. Instead, there can be message routing in a platform that actually routes that message to the right nurse on call and escalates it. So these are just a few ways and a few things that we do that just give that time back to the nurse and really lets them end their day and feel like, I had an okay day. So we have to keep focusing on that while that pipeline of new nurses is being built.
Mhm.
I think that's
Absolutely.
interesting. Like, so what do you think, like when people come to you for advice, when you're going to those events, what do you tell them? Do you say, try us out? Or do you give them, like, what advice would you give people besides try us out, which we agree with?
Focus on what we say is focus on providing tools to your nurses that makes their job suck less. And I'm quoting Megan here. We were having a conversation before we hit record on this, and it's true. So whether they use CitusHealth or something else, like it's there hasn't before really been a focus on nurses' well-being, because there hasn't had to be, frankly. Now, when there is such competition out there for nurses, where they can go from a home health care provider to a hospital and get a $30,000 sign-on bonus, and they can get 5 job offers in a week, there has to be a focus on that nurse well-being. And in all my 15 years of being a nurse, I've never seen nurses kind of quote unquote chase the dollar the way that they are now. It had never really been seen as a profession of people going to find the most competitive salaries or anything, but it is that now. So focus on what makes their lives easier. And then if they want to talk more about what makes their lives easier, we give them very simple examples, very low hanging fruit examples. It could feel really hard when you're already short staffed to think about implementing technology. And if you think about that, that's like saying we're too busy to implement something that makes us less busy, right? So we walk them through some of that, and how do you do it, and what is the benefit for you, and getting leadership's buy-in so that those nurses can see, wow, this organization really cares about me. And in fact, we see some organizations using it as a recruitment tool, not just a retention tool, but out there recruiting nurses that way and saying, hey, you're probably used to being on call 5 nights a week and having your phone blow up, while you're putting your kids to bed. Here's what we do so that you can have a life back,
Yeah.
Right.
I like that.
Yeah. And, we've talked to a lot of, a lot of technology providers now about, how technologies are doing that. And it is, I think when we first started the conversation, it was, the HR and how much technology was, creating burnout or creating frustration, but now it really is coming in and providing solutions, particularly because I think both the patients and the doctors and the nurses, they're all there, right? And so it's become, because you can connect people in this more continuous way. But as we are running out of time a little bit, why don't you give us a little bit on, just what you see is coming for both Citus and for you, excuse me, and, in terms of kind of where things will go as this technology adoption continues, and we take a, sort of more patient-centered, but focused on the wellness of the clinician and their well-being as well.
Absolutely. I mean, we have had our eye on the home since the beginning of the company, and now I think what COVID has shown us is the home is the center of our lives. One of the silver linings, I guess, of this pandemic has been that the home-based care market, which is near and dear to me as a home-based care clinician, is finally getting the recognition that it deserves from physicians referring to it, realizing that they could free up beds in the hospital, payers understanding the value it provides them, that it's the lower cost of care by far, and patients wanting to stay in the home, not wanting to expose themselves in the hospitals and things like that. So our focus will continue to be expanding into more areas of home-based care, continuing to integrate further interoperability with all of the major EMRs, because we know we can't be successful in a silo. So we already have great integration with many of the core EMRs, and we'll continue that. And providing frictionless care really in an omni-channel way. So we, in our roadmap and what we've done over the last year or two, is say, let's give our customers, who are the home health providers, the ability to offer that care in the patient's preferred method of communication. So maybe that's with an app, or maybe that's appless, where the patient can just engage through a simple text message or through a simple email. So we're going to continue focusing on that, and really looking at remote patient monitoring. So how do we connect those devices so that our customers, those care providers, can know when something might be going awry with the patient and intervene, keeping them out of the hospitals. One of the big shifts right now that we're all hearing about is the shift to value-based care. So away from fee-for-service, and these home health providers have to negotiate these contracts with, these MA plans that are reimbursing at a lower rate than traditional Medicare plans, but they can come to the table with these MA plans and negotiate favorable rates if they can show favorable outcomes and that it's actually valuable for that payer. So how can we continue to help our partners keep patients doing well under their care? So that's our roadmap. And that's what our continued focus will be.
Well,
I love that.
yeah, me too. And that's a great focus and a great way to wrap up. And so thank you. Congratulations. I'm excited to be able to say I knew you when. And it's just exciting to see, it go from idea to a successful product, in the market, and serving patients and nurses on both sides. So thanks so much for being here. And we look forward to talking later, hopefully at the roundtable, and we'll have questions from the audience then too.
Wonderful. Thanks, Megan. Thanks, Janae. Great to be with you today.
Thank you.